Let's talk about some of the other aspects of it. What about the toxicities? Adding antibody, just to touch on toxicity, does that add any new toxicities in the upfront setting?
I mean, mainly it's cytopenias. That's what we've really seen. And I think that's, and neutropenia and lymphopenia too. And that's manageable. I think this is manageable.
Do you see any increased rates of infections?
You can. I think practically it's, again, manageable depending on how you use it and what kind of prophylaxis,
Has it prompted your programs to add antibiotics prophylactically?
We're studying the question, and so we're doing a comprehensive review of patients looking back over the last several years who have had early death and to try and understand what are the causes and whether there's an excess, where there appears to be early risk of serious infection that should warrant the prophylactic approach. But I think the recent study that was published showing a potential overall survival benefit in the UK population with prophylactic antibiotics is very provocative, and I think that could potentially mitigate whatever increased risk of infection comes with these more intensive regimens.
This is from the British presentation.
Yes, correct.
Yeah. We have at our institution not implemented any prophylactic antibiotic use, but we are looking carefully. So far, there is no.
I think an important issue with that is myeloma causes infections, right? So in that British study, these are not potent PI imid-dex. There are a lot of melphalan-based regimens which are slow to respond, and so clearly if you're not controlling the disease quickly, that can also contribute to infection. So I think, but I do think DARA does add especially respiratory infections, so I do think we need to be paying attention, particularly in the older, perhaps fragile patient population. But I think the other toxicity that's worth mentioning is the stem cell collection issue, which is that, we know that CD38 is expressed on myeloid precursor cells, and that's probably the mechanism of the increased neutropenia with the addition of DARA. But in the Griffin study, there's a slight decrease in the stem cell collection, and in Cassiopeia, there was more need for plerixafor support.
But that's important because Cassiopeia was a transplant study,
right.
So it does show the
Which is
basic
Griffin
stability.
Yeah.
Right, okay.
Right, but people were still able to be collected in Griffin pretty well. I mean, the difference between 8 or 9 million or 7 or 9 million cells, I don't think is big enough to. That wouldn't drive me as much.
I think, well, the medians may not tell the whole story,
Yes,
though,
yes.
right? Because the typical patient, but then if you have the extremes of failures, having to recollect, having to
Yes.
go back to Cy mobilization.
Yeah, those
And
people-
another important distinction between Griffin and Cassiopeia is Europeans who routinely use cyclophosphamide mobilization.
Right, which we don't.
And we don't. So
Well,
part of
Alvas.
the lack of difference, part of the lack of difference in the Cassiopeia in Europe might have been the Cy mobilization, whereas in the US, the protocol mandated G and plerixafor, not Cy, unless you failed, right?
You could
So, right.
I agree in all these things, and adding one extra detail from my experience, I think if you do 4 cycles and collect, which has been the standard since the older regimens we used to have, and if you do 5 or 6 or more cycles and you collect, so we have tried with VRD and KRD after 6 cycles versus 4 cycles. In our hands, there is no difference in the yield for collection, but if you start adding daratumumab, we have seen if you do 4 versus 6 cycles that the yield seems to, on average, go down. There are patients who can still collect more than 10 million at 6 cycles, but there is a slightly lower yield if you go beyond 4 cycles.
And I think the other thing to keep in mind is with the CAR T era, where more and more patients are going to get potentially pancytopenic, I've needed to use stem cells as a boost or rescue from CAR T failure. So I think just eking out 8 million may not be enough. So that's where these small
Depends
differences.
on how many bags.
Yeah, but this may be an issue for young, fit patients who are like, we all have these patients who are below 40, and we want options for these patients going
We've actually
forward.
changed it so that now we are going to definitively collect more for the patients that are a little bit younger, understanding that they may get a transplant, maybe 2 transplants, or have several boosts in order to make eligibility for CAR T, and then maybe potentially to recover from CAR T, although we don't know.
So before we go to the next case, I have a second case I would like to present here. I have one last question, just very briefly around the table. Do you use MRD testing? We could talk about high rates of MRD negativity. Do you use that in your standard of care setting, Nina?
I use it to give me information, but not make decisions.
How about you, Ajay?
The only time I ever act on it is if it's a standard risk patient who's having some toxicity with therapy and there's a discontinuation. But other than that, I'm not acting on it.
And how about you, Alfred?
Same, not even getting it routinely because I don't think there's a lot of data to support actionability right now.
And you?
In my clinic, as I have given talks about many times, we implemented actually 5 years ago a paradigm where we have started giving 6 cycles of therapy. We do check for MOD status, and if patients are MOD negative in the newly diagnosed setting, we give the patient the option to collect and store the stem cells and go right to maintenance versus going to a transplant with maintenance. If they are positive, we would counsel them the standard route through transplant. And 5 years later, it's not a randomized study, but 5 years later, I can tell you I don't have any gut feeling that there is any difference in outcome. So that's obviously a controversial question. And all patients that come to us, we say there is no randomized data to fully know that. We don't think there is an overall survival difference. There may be a slightly shorter progression-free survival, but we think it's fair to involve the patient in the decision making.
And when patients progress, I assume that there's consideration of transplant at that point, right?
At that point, patients are offered transplantation, absolutely. But they're also offered other drugs as well. So that's another long question.